Okay, so the least threatening of all these things that we can do to people is probably the sulcus sign, right? But it also probably tells us the least. That doesn't mean it's a bad test, it means it's a starting point for us. So to do a sulcus test, you recall, you're going to grab the bicondylar eminence. It's usually better if their hand is supported, right? You have to stabilize the patient more so than the scapula, but to some degree you're stabilizing the scapula. But if I just pull here, all I do is pull him over, right? The nature of a glenoid is that it is tipped slightly up and slightly medial, right? So if it's tipped slightly up and I just pull straight down, I'm pulling into the bottom of the glenoid. That's why it's actually a little better to pull a little off the side. But a lot of times we'll do it straight down. If they're unstable here, they're probably going to be worse here, right? So earlier I had you palpate the acromial arch, right? In the clavicle where the acromion comes in, the AC joint, and that's the acromial arch, and he's a good one to feel because there's a nice ridge, and my finger's pushing up into his acromial arch, creating impingement so that he'll be sort of long. So I want to lay my finger right along his acromion, grab the bicondylar eminences of the distal humerus. I'm going to stabilize here and pull straight down. And what I am feeling and looking for is the creation of a sulcus or a concavity here. We'll have some big ones in this room. Start easy. You could, in theory, pull somebody into the capsular redundancy inferior, which we haven't talked a lot about the capsular redundancy, but we are going to do that when we talk about shoulder instabilities, whatever day Jason lets me come back. Right? Which day is that? 14th?
Thursday.
Thursday. 15th. Right? So to start, you're better off just stabilizing the patient, visualizing the acromial area, and doing a traction. And you gradually add force. Can you all see that? Sulcus occur? Then to start measuring it, you actually put your finger in it. How much of your finger going in tells you whether it's grade 1, 2, or 3. Biggest thing we're looking for is differences. He's actually probably a little bigger on this side, in my opinion, just eyeballing. But all of this has to be married back to the history, right? And what his current level of symptoms are and all of that. If he dislocated falling off a ladder this weekend, I'm not doing this test at all, okay? So that doesn't tell me much except that he is at least some laxity in his shoulder, probably both front and back in order for it to go down. Everybody with me on that? So now we want to start isolating and knowing why. The next easiest way to do that is to look at what's called a load and shift test. Loading, you want to find the posterior margin of the humerus with your thumb, the anterior margin of your humerus with your forefingers. Loading is just compression because gravity wants to draw the humerus down. So the first thing we do is compress the joint a little bit, and that slides it into the middle of the glenoid cavity. And then we load him anteriorly, posteriorly, start gently. I have to stabilize here, so I'm pushing his scapula forward when I'm drawing posteriorly, and I am stabilizing him anteriorly when I push him forward. So I'm stabilizing the scapula that way, pushing that way. With me? So this would be a test for anterior instability and specifically which ligament? Good. Superior glenohumeral ligament, which is not a true ligament. It is a capsular thickening. We learned that this morning too, right? Do we do a load and shift at 45? I don't know why you couldn't, but it is not clinically described that. It would be more for the middle glenohumeral. And you, I suppose, could do it up here, but I'm going to show you a different way to do that. So that's for anterior instabilities and posterior instabilities. We'll have probably someone here that I can shift out, at least sublux. So be careful with some of these, particularly the load and shift. And don't go crazy with even your sulcus, but chances of dislocating somebody aren't that great with it. This one I have. I told you I've relocated people doing that to come in dislocated. All right. So that can be anterior or posterior. Now, this group starts where we have huge mechanical advantages over our patients, right? So we're going to be very cautious with the application of these. I know if they have issues up here, then they're going to be compounded down here. Everybody with me? So let's lay down on your back. I like the apprehension / crank test, right? And I like the relocation test. So to do those, where do most dislocations occur? Anterior. And which ligament is most often involved?
Inferior.
Inferior, which means they occur at what arm position?
90 degrees.
Very good. 90 degrees with external rotation. So mechanically, I'm going to do this so you guys can see and that you can't. That's my objective in life, Jason. So this needs to have support, so how that can come up.
Take it both sides and wiggle it.
Both sides and
Well,
wiggle.
no, just the, yeah.
How's that? There we go. Okay. So a crank test, you're literally using his arm as a crank. I always do a crank test already in the stabilizing position. Although you will see in the literature, do that and then add this. I really recommend you not do it that way. So we just take it back to the end of the range of motion, a slight overpressure, stabilizing but not pushing with my stabilizing hand. I like to watch patient expression, but then also to ask them to verbalize, oh, I don't like that, or that hurts. Okay? That bother you at all?
Stretch.
I didn't overpressure you very much. So if I took him and said, okay, does that bother you? And he goes well below 90. So he clearly doesn't have a frozen shoulder, right? So he said, oh, that does hurt, right? Then I stabilize him. So my hand is becoming basically the anterior-inferior glenohumeral ligament. And look what happens to his rotation. Right? Now that's not a license to just see how far it'll go for fun, right? But you will have, and he's not likely to dislocate as long as you're stabilizing humeral head. Now, this you got to make sure you're not on the pecs, because you're not helping here, right? So you got to get your hand out over the humeral head to stabilize him. Now, what I would really do this test, just to block your vision, is this way, right? You can put a tau fulcrum here if you want, or a roll, but not necessary. So that's a crank test or an apprehension test. Relocation test is to just add pressure and see if that relieves their symptoms. With me? What type of instability are we testing? Very good. All right. So, then we can also do drawer tests, anteriors and or posteriors. Now these can be broken down to different angles. So if I do a posterior drawer at 0 degrees of abduction, or in adduction, that would be for which ligament? What's your question? There's no posterior ligaments, right? So it's posterior capsule. Should you differentiate? Doesn't hurt. But for a posterior drawer or posterior shear test, we've got to get him so the bed's not stabilizing him, right? So I'm going to bring him out to the edge of the bed and make him feel a little bit uncomfortable. Now, what position do I want his arm? Not so much worried about rotation, non-neutral rotation here. Do I want him in pure abduction? No, I want him in slight horizontal flexion. Same thing's true for glenohumeral mobilization, by the way. Because why? What did I tell you about the tilt of the glenoid?
It's more in adjust that.
So it's tilted, if this is the glenoid, it's tilted slightly like that. So if I have him all the way back, all I'm doing is pushing into the rim of the glenoid. If I put my posterior drawer force or my mobilization force that way, then I stretch capsule, not push the humerus into the glenoid. So here, I'm forcing the two bones together. Make sense? If you look at Wilk's work on shoulder mobilizations, that's exactly how he teaches you to do a posterior glide of the humerus. Now, this goes back to that relative force advantage that I mentioned to you. Right? I'm a big boy, with a patient in a vulnerable position. I'm not leaning on him. This is where Erica's really good about showing you the force translations. We don't have to be doing large movements with these patients in order to gain capsular mobility. Okay, and you can stretch the capsule in different points doing posteriors, right? But this is more a stability test, not talking about so much mobilization here today, right? Some people also do anterior drawers in this position, and I don't mind that. If you're a smaller person, it's easier to do prone, which we'll see in just a moment, but you have a huge mechanical advantage. So to do it anteriorly, all I'm going to do is stabilize his arm against my body. I'm going to stabilize his scapula so it can't come forward, and I'm just going to do an anterior drawer. Can you see what's happening maybe? What ligament am I testing now?
Anterior.
Anterior inferior, GHL is what you'll see, AIGHL in the literature. We've got this whole alphabet thing going on the shoulder, pasta lesions and glad lesions and AIGHLs and all that. So I bring him down here. Now this is one, the anterior drawer is one that you would repeat at 3 tests positioned, right? So 90 is the most likely to be positive because most commonly it's the anterior inferior glenohumeral ligament that's involved. 45 is the middle glenohumeral ligament. Same thing, if I just hold his arm against me and stabilize. And again, I've got these wonderful big hands, so I can do a nice anterior drawer test. And then a little harder, but you can just lay his arm here and stabilize for the superior glenohumeral ligament, right? Also in this position is the fulcrum test, fulcrum test. Usually done for anterior instabilities, can be done for posteriors. So to do a fulcrum test, I need a towel. Again, we have a big mechanical advantage. Slightly that way now. I use my hand. You may have trouble with that, and the reason that it's a disadvantage, a fulcrum test is just creating a lever arm system, a leverage system. So my hand is now the fulcrum as a fist, and then I push straight down and lever the cervical forward. Now, you'll see, and he feels tension in his capsule, but you also see the scapula coming forward, right? So it's a little better for some people to have an artificial fulcrum. Towel's probably too soft. You need a wedge or something, high density foam, like a half roll, something like that, so that you can stabilize the scapula and then push. Now I suggest you start proximally, because what happens when we use a longer lever arm, we get more leverage, right? And frankly, I don't use this test a lot unless I'm just really a little bit befuddled with the patient. It's a good test, but you have such leverage over your patient. Same thing applies then, angular, 45. Hard to do a fulcrum in this position because the bed usually gets in your way, but you can do it at 0 degrees if you want. Okay? Flip him on his tummy. For the sake of argument, this is now the bad shoulder that we're testing. We've already tested the other side. So now we can do the same thing for a posterior fulcrum if we so desire, right? And that makes it now posterior capsular test because there's real no thickenings for ligaments. More importantly, we can do our anterior drawers. He is not far enough forward, is he? I'm just pushing him into the bed. So it's a little awkward. I got to get him out here where the, come on over this way for me. Good. Okay, I'm going to stabilize here. I don't have to worry about providing scapular stability because the bed is preventing anterior translation. 90 degrees, anterior drawer. Be very careful. Can't emphasize that enough. 45 degrees. I'm doing the exact same thing I did on his back, right? It's just if you're having trouble controlling the arm, then you can do it in this way. For me, clinically, I usually don't even have to go to these tests. Most people that have had a traumatic dislocation, they know it. They usually usually know which direction. But again, if you're working sports medicine, that kind of thing, or you're doing a screening test, or have that little girl like I had this morning that had not had diagnostic stuff, and I knew she had instability, then I have to break it down, right? Okay, so we did anterior, posterior, good. All right, you can sit up, please. Boy, we're running out of time. I'm going to show you quickly O'Brien's and a biceps load test, and then the AC test we'll do real quickly. O'Brien's test we talked about at some length this morning. It's a test for?
Bicep?
No, not a test for bicep.
Tears.
Slap tears in particular, right? Using the biceps as the test mechanism. So Steve O'Brien out of Hospital for Special Surgery in New York is the one that wrote the original treatise on the test. It actually has stood up pretty well, although most of the slap diagnoses I get clinically are from MRI. I do use it some clinically and then go back to, I think they have a slap test, what do you think? Or excuse me, have an O'Brien's test. So you want the patient in a little bit of horizontal abduction. That puts a little more tension on the biceps. The more I come into horizontal adduction, the less tension is on the biceps, right? Make sense? You can either, I don't care which way you start, and I don't remember how the textbook says it, but you start with internal rotation, which puts tension on the biceps. And if there's a labral tear, the biceps tendon is usually where it starts from the peel back mechanism we talked about, right? So I ask the patient to hold it up there. I'm going to stabilize the scapula, push against me. Ooh. I feel a plunk in my shoulder or I have pain in my shoulder, right? Could it be impingement? Absolutely. But what you're really feeling for is a little bit of a slippage or a plunk. But I take pain as positive. And then you repeat it with the patient in external rotation. If the plunk goes away because there's no longer tension on the biceps tendon, it's in a shortened position, then that's supposedly indicative of slap. Decent reliability, specificity. We're going to see that when we do the instability test. So that's O'Brien's. How different is that from Speed's test? And I didn't talk about Speed's test this morning, but that's for that bicipital tendinosis or instability. So Speed's test is I put pressure and I have the patient turn over and back. So you just do this, right? And you're feeling for a clunk or a click or pain, but it should be more down in the transverse ligament where it covers the bicipital groove. So that's confusing. It does look a lot like a Speed's test. Some people do a Jurgensen's test, and I didn't even put it on the board. What you're doing there is palpating the groove and asking the patient to internally rotate and then externally rotate and seeing if the tendon pops out of the groove, right? And not a common thing you're going to see. I don't see very many transverse ligament tears at all. I see biceps tears in association with rotator cuff tears, or I see biceps tears distally. So that's O'Brien's. I did put the biceps load test. That was written by a non-colleague. We'll come back to that. The shear test, you guys asked me about that this morning. The shear test is to take thenar and hyperthenar eminence and press on his clavicle. So that's why we had to find that this morning. And the bed's in my way. I would have him down here, but that's okay. So I'm going to compress posteriorly over the clavicle. Use something broad, not your thumb, it hurts. And I'm going to find the spine of the scapula and compress anteriorly. And you're feeling for translation here, so you're just doing that. Positive either for motion or for pain in the AC joint. Problem is, doing the test, you can't really feel the AC joint while you're doing it because your hands are busy, right? And that's probably the best AC test. The AC compression test is a horizontal compression and just overloading the joint. And the AIP, we already talked about, is that active impingement test, just putting them in the same position and getting into that position. Okay? So I skipped the biceps load test. Flat on your back one more time. Jason, you're going to have to cancel this second lab. I'm tired.
Okay.
Biceps load.
I wouldn't care.
Yeah, they'd probably love it. Biceps load test is a 90-90 position, right? And all you're doing is palpating the bicipital groove as best you can and asking the patient to pull towards their nose and if that reproduces their pain or if you feel a click. Again, you're using the same mechanism. Non-colleagues originally wrote that test at a 90-degree angle, then revised it and said it should be done at 120, and then the final revision was you should do it 90 and 120, right?